Welcome, everybody. It's so nice to see so many of you here this morning. So I'm going to be talking about GABA. What's GABA got to do with it? RIP. My name is Dr. Scott Sherr. I'm the Chief Operating Officer of Health Optimization Medicine and Practice, our nonprofit organization training doctors like you and practitioners like you how to optimize health rather than treat disease. And I have a lot of fun with this talk. This is something that actually Dr. Ted and I, but mostly Dr. Ted, developed as a strategy for our overall understanding that nobody remembers the most important neurotransmitter, in our opinion, GABA. Everybody remembers serotonin and dopamine and norepinephrine. These are the fancy ones. Everybody knows about these. But everybody forgets about GABA. So this is going to be a talk on how GABA is made, what GABA is, and why we should care. Let's talk about top symptoms of GABA deficiency. So if you have a clinical practice, you probably have some of your patients with these symptoms: anxiety, fear, depression, a short temper, phobias, impulsiveness, disorganization, addictions, schizophrenia, obsessive compulsive disorder. Any of your patients have any of these? Probably, right? But you're not thinking about GABA deficiency most of the time. And then systemic symptoms. These are also associated with GABA deficiency: IBS, diarrhea, high blood pressure, tinnitus, chronic pain, migraines, allergies, frequent urination, flushing, sweating, salt cravings, muscle tension. So all of these could potentially be showing you that your patients and clients may have a GABA deficiency. It's not the first thing on many of our radars, of course, but maybe it should be part of that initial understanding of what might be going on. GABA is really important, and now even the drug industries are getting the idea. So this is the first drug approved just recently. This is a New York Times article. The first pill for postpartum depression, and it's called zuranolone, I think is how you say it. And it is a positive allosteric modulator of the GABA receptor. We'll talk about what that is. But it's supposed to be used for the first 14 days, only for 2 weeks, supposedly while you're taking another drug like an SSRI for that to work. But these work right away because it's affecting the GABA receptors directly and improving depression almost immediately too, which is pretty awesome. You don't have to go directly to drugs, of course, but sometimes they're necessary. So let's talk about GABA synthesis. GABA is only made in the brain, okay? You have to have glutamine, which is an amino acid. It's converted into glutamate in the brain, and then glutamate is our excitatory neurotransmitter, and you have GABA, which is our inhibitory neurotransmitter. So 20% of the brain's neurotransmission is actually GABA, so it's a huge amount. And glutamate and GABA combined is about 80% actually. So it's the combination of the two is the majority of your neurotransmitter system. And to make glutamine into GABA, you need this enzyme called glutamine synthase. And then from glutamate to GABA itself, you have to convert this. You need vitamin B6 and you need magnesium. So you need cofactors along the way to make this conversion happen. Some people are really great at converting GABA into GABA. Some people are not very good at it. And a lot of times it's related to these cofactors, but there's other reasons too. And here are some of those reasons. So if you have a high copper level and a low zinc level, you're not going to be able to actually have the GABA receptor work as effectively. If you're vitamin B6 deficient, you're also not going to convert well from glutamate to GABA, as I mentioned. If you have chronic stress, if you have chronic hypercortisolemia, if you're always stressed, you're going to deplete your GABA system, and then your GABA levels are going to go down. If you're magnesium deficient, and most of our clients and patients are magnesium deficient, they're not going to convert well either. If you have infection, this is going to stress the system and also decrease GABA levels. Now, GABA supplementation may help your GABA levels, but actually under most circumstances, it's not going to, because GABA itself is a big molecule and doesn't go across the blood-brain barrier. Under certain circumstances, it may, and we'll talk about that. And then probiotics can also help with this conversion, help with this enzyme. So you can actually measure, and you saw some of these slides with Dr. Ted, you can actually measure people's vitamin B6 level. And if it's low, it's very likely they're not converting well from glutamate to GABA. So this is something to be think about, and this is why we do metabolomics testing as well. You can check their magnesium level. In this patient, in this client, it was a normal magnesium level. This is red blood cell magnesium. But in a lot of our clients, it's going to be low. So if you have a low magnesium level, if you have low B6 levels, you're not going to convert well from glutamate to GABA. This is the GABA receptor. You don't have to worry about this too much, just to know that it's a pentameric structure. It's got 5 subunits, and these subunits change depending on where the GABA receptor is in the brain. Sometimes they'll look one way and they'll have various combinations depending on what they're doing. GABA is everywhere in the brain, and these GABA receptors, the subunits change depending on what's required and what's going on in that particular area. So this is the mechanism of the GABA receptor, GABA A receptor, so we're going to start with GABA A here. So you have activation of the receptor, you have opening of the central pore, you have influx of chloride, you have hyperpolarization, you have decreased occurrence of the action potential. So this all is saying that you're inhibiting the actual firing of this particular neuron that has the GABA receptor. So you're inhibiting the action potential. So you're stopping things, you're calming things down in general. Chloride goes through and it hyperpolarizes. This is the GABA B receptor. It's called the G protein coupled receptor. It's a little bit different, and it's called a metabotropic receptor, and I'll show you what this means in a minute. This is GABA B. So GABA B itself, what it does, it's a presynaptic and postsynaptic. So presynaptically, it's preventing here the release of an excitatory neurotransmitter, glutamate, which is what we've been talking about before, is the conversion of glutamate to GABA. And then you have the postsynaptic here, which is increasing potassium outflux, which causes the hyperpolarization. So a little bit different, and there's a different distribution of the GABA B receptors in the brain. So here's a quick summary. So GABA A it's called an ionotropic, or it's a ligand-gated channel opening, and it's a pentamer structure. It's widespread, has postsynaptic influx. Its endogenous agonist is GABA. You have other drugs acting on it, which we'll talk about in a minute, pharmacological actions here. And then GABA B is, as you see here, it's also widespread. It's metabotropic. It's presynaptic and postsynaptic, and it has these particular pharmacological actions as well. All right, so there's a couple definitions here. So orthosteric ligands, these are chemicals that interact with the same binding site as the natural endogenous chemical. In this case, we're talking about GABA itself. So an allosteric ligand or allosteric modulator is something that works by modifying how the receptors behave when it's bound to the orthosteric ligand. So in this case, we're talking about a separate site away from GABA that binds this particular modulator and then makes GABA work better, or helps the binding or improves the chloride channel opening. And then a positive allosteric modulator is something that binds and it causes this positive response where you have an increased affinity of GABA to bind, you have more chloride going through, and you have more hyperpolarization. So this is a picture of the GABA receptor and ligand. So here's a couple examples of what it looks like to have where GABA is binding and where some of these other drugs will bind to. So you have alcohol. Everybody used to love or maybe still loves alcohol. It's got a very high affinity for the GABA receptor, very, very high affinity. Benzodiazepines here, very high affinity as well. Has anybody ever used flumazenil before? I used it a couple times in residency. I don't recommend it. It causes seizures because it has the opposite effect. It's a GABA antagonist, so it prevents the chloride channel from opening. Zolpidem, which is the Z drugs, Ambien and others, they bind very tightly to the GABA receptor. Quaaludes, anybody ever tried a Quaalude? I don't know how everybody, yeah. Dr. Ted, no. This is back in the 70s. So, but they also were a GABA binding here, an allosteric site. Barbiturates, which we use sometimes for alcohol withdrawal, actually. Sometimes we'll still use those, but pretty much not used otherwise. General anesthetics. And then finally, the GABA is where it's GABA binding itself. So that's where GABA is binding. And so all these other sites on the GABA receptor are places where other molecules can bind, increase or decrease the affinity of GABA binding, and increase or decrease chloride channel opening. On the right side of your screen there, you can see just a top view of the same thing happen. Benzos are probably the most common positive allosteric modulator of the GABA receptor that we use. Unfortunately, benzos have a very high affinity. We're talking about Ativan, Xanax, Valium, those kinds of drugs have a very high affinity for the GABA receptor. So when somebody's taking these medications for long periods of time, they cause tolerance, they cause withdrawal, they can actually cause hallucinations and death and all those fun things too. So, but you can see here that what I wanted to point out is that there's different subunits. So the alpha-1 subunit of the GABA receptor is associated with sedation and hypnosis. So this is actually a lot of your Z drugs, like your Ambiens and Lunestys of the world. And then your alpha-2 subunit is more of your anxiolytic and muscle relaxer. So this is where your benzo is going to mostly bind. So in general, positive allosteric modulators are less addictive overall. However, that's not the case, obviously, for benzos and barbiturates and alcohol. But some of the natural equivalents that we'll talk about do have less of affinity, but still have significant impact. So drugs that act on the GABA B receptor, the most famous being GHB, gamma hydroxybutyrate. GHB is well known as the date rape drug, but it's actually a fantastic drug for muscle relaxation, sleep, and has lots of great other indications, including narcolepsy, actually. If anybody listens to our podcast, the Smarter Not Harder podcast, I had a really great conversation with a guy named Dan Party, who was involved in getting GHB to market for pharmaceutical reasons. It was a very interesting talk with him. So we're going to switch over here. So GABA in general, the cells that have GABA receptors are mostly what we call interneurons. These are neurons that are between neurons, interneurons, and they're really important for learning, for memory, for behavior. They're kind of like the way stations between sensory and motor processing. And even though they're really small, like if you can't really see it here, but it's a tiny one, like the GABA here, but this is the big dopamine receptor neuron, the big 5-HTP, the big serotonin neuron here, but you have like the small GABA. This is doing a lot of the processing between them. So they're extremely important, and they're actually in these locations to make sure that they can actually be those way stations to prevent signaling. Oftentimes in our brain, it's actually preventing signaling that's most important, not propagating, interestingly enough. So we're going to talk about how you can dim your GABA switches without a prescription required. But the first thing to say is that most GABA supplements don't work. And I was mentioning that earlier. It's because GABA is such a big molecule, it doesn't get across the blood-brain barrier. If you do have patients that are taking GABA and they are getting an effect, it could mean that they have a leaky brain, leaky gut axis, potentially. There are some formulations, maybe nanoliposomal, for example, that may work. But in general, if they're getting a significant impact from GABA itself, at least clinically, I've seen that they often have a leaky gut, and that usually means they have a leaky brain. I don't like telling patients they have a leaky brain because that doesn't sound that great. I usually say that your blood-brain barrier may not be as great as it should be. But anyway, so you can also, of course, give glutamine and glutamates. So glutamine is an amino acid. It's in various types of foods, meat, spinach, and fish as well, of course. And so you can get glutamine from a lot of different sources. But what we do in health optimization medicine and practice, we test for these kinds of things. We test vitamin B6. We test for magnesium. We test their glutamine levels, and we can tell. And if they have a certain symptomatology and they have certain cofactor deficiencies, well, we know that they're probably GABA deficient too. MSG, everybody loves MSG. Everybody actually doesn't love MSG. It's monosodium glutamate, right? This is what you can get in Chinese restaurants. They make the food nice and sweet for you, but you get a headache. That's because you get all of a sudden this huge rise in glutamate, and you have to get that conversion over to glutamate to GABA, and that can take some time. And nicotinamyl GABA, so this is a really cool form of GABA that's attached to a vitamin B3. And when you do this, you actually allow this molecule, nicotinamyl GABA, to get through the blood-brain barrier very easily, and then it hydrolyzes to vitamin B3 and GABA. And when that happens, you get this nice vitamin B3 effect, which is mild vasodilation and mild energy production. At the same time, your GABA itself getting into the brain, increasing your GABA ability and increasing GABA binding to its receptor, so relaxation. What's nice about this is it's not very sedating for most people. So if you have anxiety and stress during the day, you can take nicotinamyl GABA and you don't feel tired, you just don't feel stressed. Anybody use valerian root before for patients? Right, so very common. This is actually, valerian root, something that actually binds to the benzo site of so it's a positive allosteric modulator of the GABA receptor. Doesn't bind as tightly, but it does work really well for some people for sleep. Kavain, which is the active ingredient in kava, it's actually a similar binding site, also a positive allosteric modulator of the GABA receptor. Hanakyle, anybody used hanakyle as well? So this is from magnolia bark, also binds as a positive allosteric modulator to the GABA receptor, works really well for a lot of people. Does anybody know what this is? It's a mushroom. It's a very famous mushroom. It's called fly agaric, or Amanita muscaria is the other name for it. Of Christmas lore, does anybody know about the Christmas tales of Amanita? Amanita has two compounds in it, mostly. It's got a lot of other things, but two major ones. One is called agarin, otherwise named muscimol, and another one is called ibotenic acid. Ibotenic acid is neurotoxic. This is the one that mostly causes the psychedelic experiences of taking this particular mushroom. But you don't mostly take this mushroom directly. The stories were that shamans would drink the urine of reindeers because reindeers would be able to tolerate this okay. And then the shaman would actually then urinate, and then other people would drink the urine. This is in northern, this is actually a great New York Times article on this with some great videos as well. But that's mostly because the toxicity is because of ibotenic acid. But agarin or muscimol is a fantastic orthosteric ligand of the GABA receptor, which means that it directly enhances GABA in the system. And it does it very effectively, but the key is to have it at very low doses. So it's a GABA receptor agonist. It easily crosses the blood-brain barrier. It's got a high potency. It's long-acting. It's about 6 to 10 hours overall for a half-life. It's naturally occurring, or you can make it synthetically. In low doses, it's safe and effective. And at high doses, it can be hallucinogenic, but usually in combination with the ibotenic acid and the actual mushroom. Non-pharmacologic, of course, yoga, meditation, breath work, anything that's going to make you more parasympathetic is also going to increase GABA tone in the brain. Physical activity also helps reset the system and the balance between glutamate and GABA. So also being physically active is also really important. And then finally, it's really important, and this is kind of the ethos of health optimization medicine and practice, is we're detecting and correcting at the metabolomic level. And so you really want to be keeping the GABA deficiency aspect of things on your clinical radar. So we test for the nutrients, we test for magnesium, we test for vitamin B6. We ensure optimized GABA production. And you want to do that as sort of your baseline for everybody. So when somebody comes to see me, I'm not looking for GABA deficiency exactly. What I'm doing is doing a full metabolomic profile, correcting as I see, and then you often will see these improvements in mood and depression and anxiety because you're actually working on that neurotransmitter system. Sometimes you can give herbals and you can give supplements and things like that to help right now. That's what the transcriptions company is all about. But the key for the long term is to really work on that foundation and optimize. Of course, you want to implement dietary and lifestyle measures to boost GABA production, considering herbal and fungal GABA agonists and orthosteric ligands to support GABA production as well. And then you really want to avoid your benzos and your barbiturates, obviously, and drugs that are going to cause dependence, withdrawal, and tolerance. I mean, that's just important for us to think about. Sometimes it's unavoidable, and I use these in my patients when they really need it, but oftentimes we can get away with not using them because we have a lot of great options here from an herbal and fungal perspective. Thank you guys very much for listening. I really appreciate your time.